Okay, hello, good afternoon. Welcome back, everyone. All these familiar faces, thank you for your supporting this. We enjoy doing it, but only if you do. And so we didn't get here in time to reconfigure the chairs. Is this okay the way we're sitting? Because I'm sure these guys will reconfigure them if you want it. I told someone beforehand that if you get tired of looking at us, you can just sit yourself on this side of the table and look that way. So it's versatile. So welcome. I'm so glad to see you. I'm really excited about this particular presentation for a number of reasons. You know, over my career, and I've told you I've been in medicine longer than I can remember, but 43 years career, you see a few things change and some of them really being innovative and changing the way we do things altogether. For instance, when I was in training, doing my internal medicine training where these guys are now, I was in St. Louis, and at that time, if you were a surgeon in training, general surgery residents, the most common thing they learned to do, they were trained to do, was stomach surgery for peptic ulcer. And just a few years after I went into training, Tagamet came out. And Prilosec and all these things, no one does that surgery anymore. And I mean, they were doing multiple cases a day, taking part of your stomach out, doing a gastrectomy. So that's gone. No, you go through surgery training now, you don't even learn how to do that. You don't have any cases. So, and then I think, stents, and we're going to actually talk about stents, but how that's revolutionized things. You know, long after stomach surgery was the most common surgery, bypass surgery became the most common surgery in the country for a while. It's not now because we do a lot of them by stents. Still have to do bypass surgery in some cases, but stents have taken the place of that for a while. Oh, and then I'll tell you something I think we'll all agree on, laparoscopic procedures. That has revolutionized things over time. Do you know that one of my classmates, when I was in medical school in Little Rock, again, I've already told you how ancient that is, but he had gone to Vanderbilt undergraduate with an engineering degree, and then came to medicine, he was from Arkansas, was trained in Arkansas, and then went back to Vanderbilt and did a general surgery residency, and while he was a resident, innovated the first laparoscopic procedures. Just amazing. He doesn't know my name anymore, yeah. But he doesn't have to practice medicine to make a living either. But these things are just, when I think of the things we used to do only by open surgery and now can be done relatively non-invasively. So that's what we're going to talk about this morning. And I just thought there are a few things that certainly are exciting to see how much easier they are and less risky and easier to recover from. So these two young doctors are going to tell us about a few of these procedures. So you will probably recognize Abir Chaudhary. Dr. Chaudhary was the person who gave the last thing here. We've changed the schedule a little bit, I'm sorry to say. We've been doing this once a month, now it's going to be about 6 weeks because they've changed our schedule of our residents so much. But we're going to be even more enthusiastic, we promise. and Dr. Chaudhary is just that way. So she was a big hit last time. Y'all talked about, I think, shoulder problems and things back at the end of June. And helping her today is Dr. Porshams. Dr. Adine Porshams is from California. He did just if you're not impressed enough by that, not everybody in Arkansas is impressed with California. So. But we can be impressed by the fact that he did a postdoc fellowship at Stanford University before he came here. So we're proud of that. We're very proud of both of these residents, and they're going to tell us about a few cardiovascular procedures that are kind of innovatively revolutionizing things. So, good.
Well, good afternoon, everyone. It's wonderful to see your happy, shiny faces again. We have an even bigger crowd this time, so very excited about that. So if we go ahead and advance to the next slide, we will reveal our topic, minimally invasive cardiovascular procedures. So the idea behind this is that, these are less risky procedures that require a much shorter recovery time, and generally speaking have been found to be a lot safer with better outcomes for the patients that receive these. So we're going to go over about 6 different common procedures for various medical conditions for the heart. So if we go to the next slide, we'll start with our first one. So talking about the mitral valve clipping. This is typically for the condition known as mitral valvular regurgitation. So as you all, I'm sure, know by now, we have valves in our heart that open and close to allow for blood to flow through where it's supposed to go. But, over time, things can happen to our valves that cause them not to function as well. Things that cause heart disease. Sometimes that can affect our valve. Sometimes infections can get to those valves and destroy them as well. So with mitral valve regurgitation, basically you have blood flowing backwards where it's not supposed to go. And if this progresses to a severe enough form, it can start to cause some symptoms that can really affect how a person is feeling and how they're able to, carry out their day-to-day activities. So this procedure, the mitral valve clipping, is really a revolutionary way to address this condition. And I have to give a major shout out to my colleague, Dr. Porchamps here, because he found these really well-made animations or videos for each of these conditions that is going to give you a really nice visual as to what is actually going where and, what the procedure would actually look like. So let's go ahead and watch this little video here.
The blue-purple splashing you see here is the problem, a backwards flow of blood from a leaky mitral valve. And the little white device can be a solution.
The mitral valve is named the mitral valve because it looks kind of like the Pope's mitre, that hat with 2 leaflets.
Mayo Clinic cardiologist Dr. Peter Pollack says this metal clip is a new option for fixing a leaflet that leaks or is torn.
What we can do with this technology is staple or clip those 2 leaflets together and reduce or eliminate the amount of leak that's going backwards.
Smaller than a dime and implanted using a catheter tube, the clip is intended for patients who are too old or too sick for traditional surgery.
They just wouldn't recover from the open chest procedure.
But thanks to this closed chest beating heart procedure, now there's another way to mend a mitral valve leak.
It allows them to feel better almost immediately.
For the Mayo Clinic News Network, I'm Jeff Olson.
So it looks pretty simple, right? It's just a clip that's bringing together those 2 leaflets of the mitral valve so that it's not leaking anymore. And like he was saying, that really helps provide almost immediate relief in symptoms. So it's pretty cool, and maybe some of you have had that or know somebody that has, and just really incredible. Slightly easier than open heart surgery. All right, let's go on to our next slide. All right, so who in here has heard of the Watchman procedure? Yeah, it's making its rounds. So the Watchman procedure is for patients who have AFib or atrial fibrillation, but more specifically for patients who have that, who need to be on a blood thinner, but for whatever reason, it's not safe for them to be on an oral blood thinner, or they have some sort of reason why they can't be on a blood thinner. Maybe they've been on it before and it was causing maybe GI bleeding, or people who are prone to falling and hitting their head. You don't want to risk putting them on a blood thinner because you might incidentally give them a brain hemorrhage, and that's a lot more dangerous than this alternative. So I'll backtrack a little bit. So people with AFib, basically the top chambers of their heart, the atria, they're not really contracting correctly. It's happening irregularly, and so this leads to a pooling of blood in those chambers. And so if you let blood pool, what happens eventually is that it's going to form a clot. And so if you form a clot, it gives the chance that that clot might shoot up and go somewhere, particularly to the vasculature that leads up to your brain. And so if it causes a blockage in one of the vessels going up to your brain, you could get a stroke. So the Watchman is great for these patients who can't tolerate or be on a blood thinning medication for whatever reason, but they still carry that risk of having a clot and developing a stroke. So we'll go ahead and watch the video now so you can see exactly what I'm talking about.
This is the Watchman implant, a one-time procedure that may reduce your stroke risk for a lifetime. If you have non-valvular atrial fibrillation, or AFib, not caused by a heart valve problem, and need an alternative to blood thinners, the Watchman implant could be right for you. AFib increases your risk of having a stroke. In fact, on average, a person with AFib is 5 times more likely to suffer a stroke than someone with a regular heartbeat. That's because AFib causes your heart to beat irregularly, which affects its ability to pump blood normally. And when the heart doesn't pump as it should, blood can collect and form clots. If a clot escapes, it can cut off blood supply to part of the brain, causing a stroke. In people with non-valvular AFib, blood clots most commonly form in an area of the heart called the left atrial appendage, or LAA. Closing the left atrial appendage is an effective way to reduce the risk of a stroke in people with non-valvular AFib. The Watchman implant fits right into the LAA, completely sealing it off so blood clots can't form there and lead to a stroke. The Watchman implant permanently reduces your stroke risk without the use of blood thinners and the worries that come with them. If you take a blood thinner, you are likely aware of the bleeding risks that come with it. Most people can take a blood thinner for years without serious side effects. But because blood thinners help prevent clots by thinning the blood, they also increase the risk of bleeding. Sometimes bleeding can be serious or even life-threatening. For instance, you may experience internal bleeding or bleeding in the brain, which can cause a stroke. If you've experienced this kind of bleeding while taking a blood thinner, or think you're at risk for this kind of bleeding in the future, talk to your cardiologist about the Watchman implant. The Watchman implant procedure is safe and minimally invasive and doesn't require open heart surgery. With 20 years of clinical trial and real-world experience, including 10 clinical trials, the Watchman implant has a proven safety record. Similar to a stent procedure, your doctor makes a small cut in your upper leg and inserts a narrow tube, then guides the Watchman implant through the tube into the left atrial appendage. The procedure is done under general anesthesia. People who get the Watchman implant usually stay in the hospital for a day or less. After the procedure, your doctor will prescribe you a choice of either antiplatelets or blood thinners. During that time, your own heart tissue grows over the Watchman implant to form a barrier against blood clots until your left atrial appendage is permanently sealed off. Many people may be able to stop taking blood thinners immediately after the procedure. And in a clinical trial, 96% of people were able to stop after just 45 days. Make sure you talk to your doctor to understand the right medication for you and how long you'll be on them after your procedure. The Watchman implant is the #1 doctor-recommended left atrial appendage implant, and it can be a life-changing alternative to the daily use of blood thinners and the bleeding risks that come with them. Get your customized doctor discussion guide so you can talk with your cardiologist about whether the Watchman implant is right for you. Go to watchman.com/guide.
So pretty cool, right? So after that Watchman device is inserted, it takes about 6 weeks for it to kind of seal off and, prevent clots from traveling up. So that's why you might still be on a blood thinner for, a temporary amount of time after the procedure. But yeah, it's just so fascinating. All right, why don't we go on to the next slide now? All right, so ablations, another pretty common procedure for AFib. So this has more to do with the AFib itself, the underlying basically electrical dysfunction that's causing the irregular rhythm. So by doing this, the hope is to get a person back into normal sinus rhythm to, help prevent some of those complications associated with AFib. And so this is generally performed by specialized cardiologists known as electrophysiologists. They're incredibly smart people. If you think your average physician is smart, these guys are like top tier smart. So, and this is typically a really straightforward procedure as well. We can go ahead and watch the clip just so you can actually see what they do for it.
There's one simple hearing.
Gotta love ads.
Catheter ablation is a safe and effective treatment option for patients with heart arrhythmias when medications prove ineffective or cause negative side effects, which may include fatigue, increased heart palpitations, dizziness, or stomach problems. Catheter ablation is a minimally invasive procedure to treat heart arrhythmias. The goal of the procedure is to restore the heart's electrical signals to a normal heart rhythm. Catheter ablation is a safe procedure performed by a heart rhythm specialist called an electrophysiologist. An electrophysiologist is a cardiologist who has completed specialized training for diagnosing and treating heart arrhythmias. During a catheter ablation procedure, a thin, flexible tube, or catheter, is placed through a small incision in the leg, where it's then advanced up through a vein and into the heart. There are 2 phases during a radiofrequency ablation: mapping and ablation. During mapping, an electrophysiologist creates a 3-dimensional image of the heart using specialized catheters in order to identify the area of abnormal electrical signals which may be causing the arrhythmia. In the second phase, ablation, the electrophysiologist directs a catheter to the targeted areas and delivers radiofrequency energy in order to create a small scar within the heart muscle. This will then block the faulty electrical impulses and restore normal electrical pathways in the heart. After the procedure, it's typical to resume normal activities within 3 to 5 days. The main benefits of catheter ablation are a reduction of symptoms and an improvement in quality of life, without the side effects often associated with medications alone. To learn more about catheter ablation or to find an electrophysiologist near you, visit www.getsmartaboutafib.com.
And so with ablations, you may have heard of some people having maybe more than one ablation. The hope is that with one, it's gonna get your heart back into its normal electrical rhythm. And some people may do fine for weeks, months, years, and then they, for whatever reason, get back in the irregular rhythm, and so they might require a second ablation. That's kind of up to the cardiologist to decide that, but just, something to take note of is that not every ablation is successful, but, it's still something that's usually worth trying as long as you're, the EP specialist thinks so. And so, you probably noted the theme with all of these so far about it being minimally invasive, where they're going in, basically, it's saying your upper leg or your groin, where your femoral artery is. So that really cuts down on the complications associated with recovery. So the next 3 procedures, I'm gonna turn it over to Dr. Porchamp so he can continue. And then after he goes through those, we'll allow plenty of time for questions.
Hi, everyone. I'm so glad to be here. Dr. Chaudhary has been a wonderful colleague, and I'm just very blessed to be here with Dr. Wright and happy to meet all of you. I'm going to go over 3 other procedures. So far, most of the procedures go through your femoral artery. The ablations actually go through your veins, so the recovery time is even easier because it's a low pressure system. And they can use up to 4 catheters, so 2 in each vein on each leg. So that's an interesting thing to think about because the next 3 procedures have to go through the artery. So the recovery time is really based on stopping the bleeding from those femoral arteries. So we're going to talk about aortic valve replacement first. And what's amazing is that these devices are actually made in different companies, but they're actually hand sewn. And they use different materials to make sure that they withstand all of the durability issues of lasting for decades inside of your body. The metal that they use now is called nitinol. Nitinol is an alloy of nickel and titanium that was actually developed by the Navy. So nitinol stands for Nickel Titanium Naval Observatory Laboratory. So it's interesting to keep that in mind, that the science behind just the materials has led to these advances in medicine. And the reason they use this material is that they need to compress it to get it into a small diameter to be able to go into your femoral artery and up to your aorta, for example, where the aortic valve would be, and then to open that catheter and let it, pop into place. And it needs to pop into place at a specific diameter. And nitinol allows it to do that. You can compress it, you could twist it, and when you release the sleeve over it, it essentially goes back to its exact shape. So with time, aortic valves can calcify, they can cause regurgitation, they can basically lead to a lack of optimal functionality of the heart. Some may know what an echocardiogram is, which gives you your ejection fraction. And if your ejection fraction is compromised, then aortic valve replacement may be an option in that treatment. And we'll look at the video. It's a short video that will show the procedure. And as I mentioned, there are different companies that have pros and cons as to what their devices can do based on their technology. But we'll watch this video and we can discuss more after the presentation. I don't think this video has audio, so I can describe what's happening as we go through. So here we have a diagram of the iliac arteries. It goes through the groin, up the femoral artery towards the abdominal aorta. And now we're extending up to the thoracic aorta. And you can see now that this sleeve is going to be retracted to allow the valvular component to get into place. It's all going over this wire that guides it. And at this point, imaging is taken live during the surgery, and the operating room gets very quiet. And once the position is confirmed, you now have this nitinol mesh attached to the walls of the aorta, covers your biological aorta, and now you have a mechanical device. Again, this is stitched by hand and then sterilized with gases and prepared for the surgery. And then you get an aortic valve replacement, and the recovery time is only 1 day. So after this procedure, the entry to the femoral artery is large enough to require 2 stitches. And those stitches are placed, and pressure is held because, again, it's an arterial system under high pressure. Pressure is held until bleeding is controlled to prevent any hematomas or leaks. Sometimes these hematomas can be serious because they're not seen right away, and at some point a patient's blood pressure could decline, and it becomes a complication. And there are other different devices that are used to control bleeding. Some of them put collagen patches under the skin, some are collagen paste, and all of these different interventions can be used to make sure that the bleeding is controlled. We'll go to our next topic now. AAA repair. So who knows what an abdominal aneurysm is? Okay, a lot of people. So some of the risk factors for developing an abdominal aneurysm include smoking, genetics, simply age-related, and besides an aneurysm, sometimes trauma can lead to disruption of the arterial wall. And even car accidents can cause G-forces that cause tears or compromise of the aorta. And in this segment, we're going to talk about abdominal aortas, but you can also have an aneurysm in the thoracic aorta, higher, closer to the heart, as we saw in that image where the aorta arches and goes to your heart. Now, you'll notice that these grafts also have the same nitinol metal, and now they have a white fabric. And different companies use different materials. Some are like Gore-Tex material that you might see even in shoes that are waterproof. And the idea is that it holds the blood within that fabric. So now you're guiding the blood through the fabric of this graft rather than through the arterial walls. So you no longer have that pressure pushing on the arterial walls and causing this aneurysm to grow. The indication, as we'll see in the video, is 5.5 centimeters in diameter for men and 5 centimeters for women. However, if it's monitored and it's growing very quickly, for example, 1 centimeter within a year, the discussion may be to have an intervention sooner rather than waiting for that 5.5 centimeter indication. Interestingly, some of the fabric that different companies use are more porous than others. For example, if you have porosity, if there's an ability for blood to seep into the fabric a little bit, some are arguing that that seepage allows a clotting factor to actually pull the aneurysm in. So if you were at 6 centimeters dilation of the aneurysm, the porosity may allow a thrombosis or a healing that pulls it from 6 centimeters into 5, and over time it may even correct more. The other option is to have that Gore-Tex material that is non-porous and just simply contains the blood within the graft so that there's no pressure on the wall, and in that regard it begins to heal. So let's watch a short video, and then we can always discuss some questions later.
What is an abdominal aortic aneurysm? An abdominal aortic aneurysm is the bulging of a weakened area of the aorta, the most important blood vessel in your body. When the bulge reaches 5 centimeters for women and 5.5 centimeters for men, or if it grows more than 1 centimeter in less than a year, then the risk of rupture increases and your doctor may consider treating it. Why? Because an abdominal aortic aneurysm is like a small balloon. It may silently and slowly grow. The more it grows and the more the walls of the aorta are stressed, the greater the possibility it could rupture all of a sudden.
So the idea is now you're putting that graft within the aorta so that it doesn't continue to balloon and rupture. Now, if it does rupture, an emergent surgery can still be done with these same devices. In fact, if there's a car accident and a young patient has a dissection of the aorta and they're actively bleeding, this same graft can be used to emergently repair the artery, the aorta, and save the person's life. Now, measurement is very important because you might have noticed the kidneys have arteries that go to each side. And this graft needs to make sure that you don't cover those renal arteries to the kidneys. So a lot of measurement is used, a lot of CT scans are used, and to make sure that they get the precise diameter and length of these grafts to make sure that they're positioned optimally so that you are below the renal arteries and within the iliac arteries. So the procedure is interesting in that it has three, sometimes two, but sometimes three pieces or components. A first one is placed within the abdominal aorta and it has two little legs on it. And those legs are used to then extend the graft with additional devices that extend into the iliac arteries. So now you have a firm placement to prevent it from moving. The nitinol metal that we discussed has radial force that pushes on the walls, but now you have a length of material that will allow the arterial intimal wall to grow into the graft. So now it becomes part of your arterial lining. And in a thoracic case, if you have an aneurysm closer to the actual heart, the same procedure can be done with the same materials and the same premise of delivery through a catheter, and then you open the catheter to allow the graft to open up. We'll go to our last and very simple topic of stenting. So stents can be used in different areas of the body. Again, if you have a stricture of the artery going to your kidney, you could put a stent there to make sure that it's open or patent. Now, for cardiac arteries, if a patient is having chest pressure, symptoms of heart attack, angiography is done to visualize how open the lumen of the arteries are. And if necessary, stents can be placed. The stents are delivered over a wire. They can be delivered either through the groin femoral artery or also through the wrist via the radial artery. The recovery time is shorter for the radial artery, but it depends on the procedure, how big the stents need to be, and also how comfortable the surgeon is. So here's just an image of it, and the idea is if you have calcification in those arteries that are blocking the flow of your blood, then these stents can open up that artery. The calcification is embedded into the wall of the artery, so when the stent is placed and it is opened and dilated with a balloon that is already prepared below the stent, now you have a situation where you press the calcification out within the wall of the cardiac artery, and now you have an open flow for blood flow and oxygenation. So let's watch this quick video. Now, while that's loading, these stents have medication on them as well. So you can see how tight that stricture is. And once you dilate that balloon, now you have the stent in place. If necessary, you can put stents back to back, or if necessary, in different vessels, different arteries of the heart, based on the assessment from the angiography. The angiography uses a little bit of dye to see how much tight the vessel is, how much blood flow there is, and then an assessment is made as to where the stents should be placed and how many. And they're interesting. These are drug-eluting stents. They have medications on them to basically prevent overgrowth of your arterial intimal layer so that it doesn't occlude again, so it remains open. And those different medications we can discuss in the question and answer section. But those are 6, I think, of the most common procedures that we thought would be most interesting. Really, a lot of it is driven by the science and development of different procedures, different materials, and it's really quite fascinating that all these procedures before required open surgery, actually opening the chest. But now, within one day, patients are going home, less infection and less complication.
Excellent. Well, I hope you found that as fascinating as I do. One fascinating thing, there are obviously great stories here in medicine and innovation in medicine. Some of you folks have been very successful business people. Are you impressed at all that the name Watchman gets on there? It's not a medical term. I don't know where that came from, but I know it came from corporate America. Everybody was equally impressed with what you've done. Yes, we'll award you this. It's not the only company that makes these, but I bet they've got the corner on the market. Most people don't know a name of any other company. And that's not the name of the company, but that's the name they chose for the procedure. So that's a backstory that I'm not really familiar with. I need to read on it sometime. Or you may want to report back. Yes, ma'am. We're going to give you a mic.
I was just going to ask why the Watchman, your body apparently grows a skin over that, and you said it takes 6 weeks. Well, how does your body know to grow that? Is it just cells upon cells upon cells coagulating?
Being stimulated. Yeah.
Okay, I'll try to answer this question. So when your body detects the foreign object, essentially it's going to heal over it. So even the grafts that we discussed for the aneurysm repair, your skin cells or the cells of your arterioles are going to grow over that. And it's actually a good thing because then the graft becomes embedded into your arterial wall. And in the case of the Watchman, the idea is that they're implanting it knowing that it's going to have that cell growth, and that prevents it from being considered in a way a foreign object. So now it irritates the cells and allows it to proliferate over it. It's actually the intended effect. Does that answer the question? Yes. Okay, good.
And what's the incidence of people that repel these? What's the incidence of that your body might not want the device in there and will actually repel it?
It's a good question. I don't know the incidence of infection or cases that it needs to be removed. That's something I can try to look up and we can discuss next time. But Dr. Wright, help me
It's a
out.
fair question. I don't know the answer,
Yeah.
except I think it's safe to presume it's pretty rare, since I've not heard of a case incident of it. But in medicine, there's usually an exception to every rule. So I won't say it can't happen or hasn't happened. But
And I was at the cardiology team at Stanford, and I never saw a patient in my time there that was going to have the Watchman removed. So I was mainly on the electrophysiology side. We were dealing with patients with ablations and anticoagulation. But I was in the operating room often and never saw a patient having their Watchman removed. A lot of cases have having them placed.
I got to tell you a quick story. It was from the days prior to these innovations, but I think some of you know my father was a small town family physician for 47 years. He had a partner who outlived him, and at 90 years old, he was living in an assisted living only because he wanted meals. You know, he didn't really need to be in there, but one night he started hurting in his abdomen. And he says, this could be an aortic aneurysm. He didn't know he had one, but this could be an aortic aneurysm. Pretty astute. He called a friend. He didn't call an ambulance. He said, the ambulance will take me to the local hospital where I'll die, waiting for a doctor to come in, because there's doctors on call, but not in the hospital. So he called his friend and made him promise to take him all the way to Texarkana, which was 30 miles, but he figured it was his one chance if he was right. And sure enough, he was rupturing his aorta. And there's a saying about aortas when in medical school. The way you survive a aorta is to be in the hospital when it starts leaking. You don't have, forever to go, but he figured going to the Hope Hospital wasn't going to get him anywhere. He's going on, and it worked. See, other questions? Yes. Yes, there are a few in town. I think each hospital system has their own electrophysiologist.
I had a question about the metal that whatever he called it, nitinol, the mixture of nickel and titanium. Is that what it was?
Yes.
Are patients tested for metal allergies before these procedures?
Fair question. Our expert on metal from Stanford is Dr. Porshams, because I don't know.
That's actually a great question. The only contraindication to these devices is exactly what you said, a nickel allergy. If they have a nickel allergy, then we wouldn't be able to do that. And from my understanding, it's very rare to have such an allergy. To be honest, it is not routinely tested. So if there's even in an emergent situation, we don't review a patient's chart to ask about allergy. Now, if it's an elective procedure and there's time to ask, then yes, we'll have that discussion about a nickel allergy. But I believe that the alloy with the nickel and titanium is very inert, and the incidence of reaction is very rare.
Yes, ma'am. So,
Get your steps in. My question is on stents. I just wonder, are arterial or in your heart stents different from iliac stents? And what's the average life of, are they the same or are they different?
That's a great question. So from my understanding, there are different stents to be placed in different areas. And they have different lengths and they have different widths. As far as material, they are quite similar. But each company will make stents that are designed for whether it's going to go into your leg or into your kidney or into your heart. But the premise is the same. They're all metal mesh over a balloon that dilates. But conceptually, they're the same. They may differ on length and diameter. And they're built that way. The box will say, this is the length, this is the absolute most diameter that you can have. And some of them are more stretchable and some are fixed. So some of them you open with a balloon and they cannot extend anymore. Some of them are flexible, meaning if you keep extending, it'll widen, but the length will also shorten. So, for example, if you have something leaking and you want to put a stent over it to cover that leak, you have to keep in mind how far you can dilate it, because if you lose that length, it may start leaking again. So some of these stents actually have a cover over it, and some are open to allow your skin, your arterial cells to grow into it. Does that answer your question? Oh, the lifespan of the stents? Dr. Wright, I'm actually not sure about lifespan. I haven't seen any fail or have to be revised.
Frankly, I don't know. It's not a common subject or anything commented on, so you put them in thinking they're going to last indefinitely, obviously, and I'm sure there are a fair number of exceptions to that, but I haven't heard an average years estimate. Yes, sir.
Dr. Wright, some of these people in here are elderly. Is there ever a time when they tell you with your age and condition they don't do this?
There is, for almost every procedure, there will be recommendations like that. Some of them, quite frankly, I think are biased. I think it represents ageism sometimes. You know, we've got so many things that we quit screening for. Quit screening for mammograms. You know, I got to say, I'm of the other school on that one. Frankly, colorectal, you know, doing colonoscopies, it's about how long your estimate longevity is the reason they free you up for that. The truth is, those are two cancers that get more common with age, so why would you want to quit screening for it? That's just my bias. There you go. But I think everything is subject to that nowadays. There are a number of things. I remember when they first started doing open heart aortic valve replacement on people over 85. There were all these people who didn't think that was a good idea. You know, obviously, in any kind of surgery, you part of the decision-making pre-op is whether a person's healthy enough. If they bring their own individual risks that are high enough, you're going to weigh that in, and maybe in some cases say, you know, I think your risk is too high, but I don't like the idea of age alone being a determinant, frankly. Just my bias. Yes, sir.
I think my question is really simple, but the tungsten alloy metal, I can see how it might be used in the wire that delivers the device. Is it also used in the stent that's left in the body?
I'm guessing so. This man's the expert on the...
I think some of the stents that you're referring to can be stainless steel. And those stainless steel ones, once they dilate, they are at a fixed diameter. But even the nitinol that we were talking about, it's not really designed to stretch, but there are different alloys that are stretchable. But the specific nitinol that we were discussing, it's designed to basically be compressed, and once that compression is released, go to the exact shape that it was designed to have. Does that answer the question? So, but as far as the regular drug-eluting stents that are designed to be straight, those can be just stainless steel, and they have a drug coating over them. But when we get into the aortic valve replacement or the aneurysm repair, you have a shape that is triangular with pieces of metal that are designed to embed into the arterial wall. They're maybe 3 millimeters long, and they're sharp, actually. Yeah.
I think I understand, and really that material is not used for the guide wire, is it?
The guide wire is separate. The guide wire is going to be a lot more flimsy. Some of them are thicker, and it really depends on what's going to go over it. The devices that we're talking about require a very thick wire because otherwise it's too flimsy. So, and initially when they put a wire into your femoral artery, it's very soft and almost plastic material, but then they have to put a sheath over that wire, pull that wire out, and replace it with the more, it's of greater caliber. It's stronger and wider. Otherwise, the device won't have enough of a, let's say, a railroad track to traverse. Okay.
You know, I think all 6 of these innovations that they've chosen to share with you are fascinating in their own right. Some a little more impressive than the others, but they're all such an innovation. Probably the one I'm just trying to think, which one has made the big difference? I think the biggest difference probably is the stents. When you think about it, everyone had to have bypass surgery. Now a lot of people are saved from bypass surgery, open heart surgery, by the stents. So that's probably had a wider, more extensive effect than the others. I'm probably most fascinated by the TAVR procedure, the transcatheter aortic valve replacement procedure. Had been doing valve replacement for aortic stenosis for decades. But no, you know, in every case, you didn't want to have to do it, but you knew that. So aortic stenosis is, as he was describing, it's a narrowing, scarring down of the aortic valve opening. So when it opens, instead of opening fully, it just opens smaller and smaller with time. And if you make a diagnosis of someone at a certain point in their life and it's mild, then you say at some point in the future, it will progress possibly to a point you have to have a valve replaced. And the only question is how fast that happens. It's probably going to be years, but is it going to be 3 or 4 years, or is it going to be 20 years? But we as practitioners would be well advised to watch a person who has aortic stenosis with the understanding that periodically, after a certain stage, they've got to have repeat echocardiograms to show us how it's narrowing. And at one point where the pressures, create a gradient that's more impressive, it's going to have surgery. The valve's going to have to be replaced with one more useful and that works, or it's going to be just progressive heart failure. To me, this has been, it was so impressive when they could do the open valve replacement. But now that you can do that through your vessels, through the circulation, and have that done is just remarkable. It's mind-blowing, really, to me. And medicine is exciting for that way. There are innovations coming along that make such a big difference. And we just think of, I mentioned my friend who was one of the innovators of laparoscopic surgery. Just think how much simpler life has become with that. For things like gallbladders were the first things, weren't they? Now hernias and a lot of other things. So it's we all benefit from this.
Please tell me some more about stents. I had a friend who commented, "Oh, I had another stent put in," more than once. How many stents does one get, and how? Anyway, tell me more about stents.
Theoretically, you could have as many stents as it took to stretch open whatever length of artery you have that's diseased and narrowed. But I've probably seen people who have had as many as 3 different stenting procedures. Now maybe they had multiple stents at each one, but I'm not sure I've seen anybody with more than 3.
I can
You
try
may
to
have-
I can try to explain a situation where someone might need more stents. In one patient, we had a curvature of the artery going to her kidney. Okay, and when they placed the stent to make it open, it was open during the time of the surgery. They checked it, but then on a subsequent scan, they found that it had curved around the edge of the stent. So now you have this straight stent, and then the artery is curving right at the edge of it. So essentially it's getting blocked again. So in that situation, you would go in and put another stent into the previous one and open it up. And when you do that, you might find that you're still in a kink. So you put yet another stent. So now you're really just building a tunnel with multiple stents. And in different situations, it depends on the anatomy. It depends on whether or not a stent fails and needs to be removed and replaced, which they can be. They can be removed and replaced with another one. So it really depends on the situation, but anatomically there are some variations that will develop that require an additional stent, whether it's in the heart or for the kidney or in your legs.
Right. You know, I might modify my answer a while ago. I find the ablation of the electrical circuitry that's aberrant, I find that pretty fascinating. The problem is, just as Dr. Chaudhary was saying, it doesn't always work. If it always worked, it would be even more impacted. But there are a fair number of people who have multiple ablations, and they work a little while for a time, but then you've either got to do it again or not.
I'm almost afraid to ask this, but can you tell us some of the symptoms we would experience that require some of these stents?
That's a good question. Dr. Chaudhary, you want to take that one?
So were you wanting to know about like the stents in particular or general? Well, I guess we covered a pretty wide variety of different conditions. So typically for patients that, require the coronary stents, they're going to oftentimes present with kind of typical sort of heart attack-like symptoms. So they may have the chest pain. They might feel like short of breath all of a sudden. Oftentimes they'll come into the ER saying, I just don't feel right. I've just been feeling very down today. Something's different. So not everyone can always qualify their symptoms that well, and not everyone comes in textbook. But oftentimes if we're concerned that you're having chest pain, you're sweating, you just don't look right, and we do some initial testing in the ER where most often we start with an EKG, which is where they place those leads on you to kind of check that electrical activity of your heart. If we find certain findings in those basically in that picture, then that can kind of set us off to know that, okay, it looks like he or she might be having some sort of acute coronary syndrome or some sort of blockage that's causing a lack of blood flow to a certain area of their heart. So the abdominal one, abdominal pain is a pretty common alerter.
Middle and often in the back.
Yeah, going into the back, you see that.
Definitely include the middle, but it would be even around the back.
Yeah.
Well, on the aorta, the abdominal aorta, I think they made a point that this can advance for a long time silently, not know it. What I would say is that if a person's been a smoker, that's a real high risk. Even if you quit smoking 15, 20 years ago, if you've been a smoker much of your life, probably a good idea to get a screening sonogram. It's just an ultrasound that will tell us whether the aorta is enlarged, and that would, because waiting for symptoms, sometimes the first symptoms is it's starting to leak, and so then it's an emergency. That's the case I'm talking about, the aortic aneurysm, but it usually will be pain when there is starting to be some leakage. So.
Yeah, and even on the flip side of that, if your aneurysm hasn't quite gotten to the point where it's at 5 centimeters for ladies or 5.5 for men, even if you still develop symptoms when it's below that threshold, you would still want to intervene right away, because any sign of symptoms is bad.
Could be anyway, and so you want to know, is that what's happening? Well, I think they did a great job. Thank you. I want to thank y'all too, because here's another group we have out here, and I just want to tell you, over the last 5 years that we've been doing this and had residents in training serving here at Butterfield Trail, the feedback from the residents to us has been consistent. What a great experience it is. And you know what they hold out most often? Almost all of them have stories about people they met here. What fascinating people and what gracious people. And I want to thank you for that, because I know that to be true also. So we recruited Dr. Chaudhary. She's way off up in Chicago. Who knows whether she knew anything about Arkansas. And then, of course, Dr. Porshams comes from California. They're thinking, where is this backwater place in northwest Arkansas? And I think we've been so fortunate. We've known for a couple of years now that she was a great find. And Dr. Porsham's just here less than 2 months, but I've already figured out he's a great find. I think I knew that when I talked to him on the phone the first time. So anyway, thank you all for your support. We so appreciate it.
Thank you.